Hi everyone, my name is Chrissie Mlynarek. I'm one of the core faculty for the Ascension Providence Emergency Medicine Residency. And as part of our faculty development, I'm going to give a short lecture here on tips and techniques for bedside teaching. Before we get to the various techniques, I'd like to just take a moment to discuss what it means to be a physician mentor. As a mentor, you practice active guidance with direct interest in another individual's development. As such, you develop an intense, personal, non-competitive relationship with a high level of commitment that is reciprocal but asymmetrical, with the primary purpose of growing and developing your mentee. As a mentor and a faculty member, what you do really matters and has an impact. The majority of medical education is done at bedside, and I would urge you to try and find the learnable moment in this time rather than the teachable moment. What I mean by that, I think, can be best explained by an example. Let's say it's 9:30 at night, your shift ends at 10, you've been working with the resident for your whole shift, and a COPDer comes in with dyspnea. They're working pretty hard, so you put them on BiPAP and you check an ABG. And about 15 minutes later, you repeat the ABG and you see that their CO2 is creeping up and their pH is going down. Now, you might have a teachable moment here where you could divulge into a long lecture about acid-base physiology, but I'd urge you to ask yourself if this is an appropriate learnable moment. Given that the resident has been on with you all shift, there's a few minutes until the end of the shift. They're probably tired, they're mentally fatigued and physically fatigued. I don't think an in-depth discussion on acid-base physiology is really going to stick with this learner at that time. It's also really important for you to remember that the education and mentoring that you provide to these residents has an impact on all future patients. So what you do, again, really does matter. The first technique I'm going to cover is called the 1-minute preceptor. So after the resident presents the H&P, you get a commitment from the resident. What that means is 1 to 2 diagnoses in their differential diagnosis. And then you probe that resident for evidence, asking them what about the H&P makes them think that one of their diagnoses is the correct one. Then you teach a general rule. For example, you may have a resident present a 70-year-old male smoker with flank pain, and their diagnoses may consist of renal colic or UTI, which certainly would be on the differential, but you would tell the resident that they might want to consider, or that they should always consider, AAA in this patient population. Then you reinforce what was done right. For example, you tell them they had a good presentation or they supported their differential correctly. And then you take the opportunity to correct any mistakes. And mostly here we're talking about mistakes in their thought process. So this whole process should take about 3 to 5 minutes, which is why I call it the 1-ish minute preceptor. And frankly, sometimes in the emergency department, you don't have time to go over all this, but on some of the slower days, or perhaps when you're finishing up and not picking up too many more patients, you'll have some time to walk through this with your resident. The next technique we're going to cover is called the SNAPS model. SNAP stands for summarize the H&P, narrow the differential, analyze by comparing and contrasting the differential diagnosis, probing the teacher, planning management, and selecting a case-related issue for learning. So if we continue the example from the previous model, the 70-year-old male with flank pain, we would ask the resident to narrow the differential diagnoses and give us the most life-threatening diagnoses and the most common diagnoses. So again, they would likely say kidney stone and AAA. Then we would ask them to analyze a differential by comparing and contrasting AAA to a stone. Then the resident would probe the teacher. So prior to presenting the case to us, they would set this up, arrange this in their head, or maybe have some notes, and they would come up with some questions they may want to ask us. Then together we would plan the management. And then we would ask the resident to select an issue related to this case for learning. For example, you might ask them to review how to diagnose or rule out a AAA with bedside ultrasound. The next model we're going to review is called the SPIT model. This is a method for working through a differential diagnosis as opposed to a presentation of a case. So SPIT stands for serious, probable, interesting, and treatable. I really like this. It allows the resident and you to have a little bit of fun. So for example, if you have a 45-year-old female presenting with chest pain, a very serious diagnosis may be PE. A probable is likely costochondritis. An interesting one may be syphilitic aortitis, and a treatable one, ACS. Bedside technique is called the teaching script. What these are 2-minute spiels that you can give to the residents when a topic presents itself in the ED. So you can think of these as either literal note cards that you carry in your back pocket with this information, or just figuratively something you can pull out of your back pocket that you know well. Different topics you can cover are various chief's complaints, reasons for choosing one medication over another, risk stratification tools, anything really that you can think of. And the idea here is that you say the same thing anytime these issues arise in the emergency department. For example, whenever a resident presents a patient with chest pain, you can go over the heart score. Or after intubating a critically ill patient, you can discuss with the residents why they would or would not want to use succinylcholine. Given that you prepare these beforehand, you can get a little bit more in depth with these. So perhaps quote some statistics or something else. This not only is an opportunity to teach the residents, but it also makes you look pretty cool. Another method is called the Aunt Minnie method. And what Aunt Minnie does is really focus on rapid pattern recognition. So for example, if you have a patient present via EMS for dyspnea, you're watching them and they're tripoding, clearly dyspneic, blood pressure is 200/105. You listen to them, you auscultate the lungs, and there's rails bilaterally. You do a quick bedside ultrasound and you see V lines diffusely. The first thing that's going to come to your mind is likely flash pulmonary edema, because this is likely a presentation of flash pulmonary edema. So it's called Aunt Minnie because if you see someone that looks like your Aunt Minnie, it probably is your Aunt Minnie. So what this teaching method does is have you suggest to the resident that they kind of take a step back and see a more global picture of the patient. While it's very important that they auscultate the lungs and augment their exam with bedside ultrasound, it's equally important that the residents obtain a more global picture of the patient. So encourage them to kind of stand back and observe the patient from there. The more they do this, the more they'll be able to recognize these patterns. I think it is critically important, though, that we start this early on. Also, something you want to do in the beginning of resident training is have the residents tell you whether or not these patients are sick or not sick. I think it's often easy for the resident to kind of jump in there and want to obtain a detailed history and do a very detailed physical exam. They come back and they present the case and they give you all of this information, but they haven't gotten a larger picture of what's going on. Under the Aunt Minnie umbrella also falls the idea of teaching the residents to think horse, not zebra. So I think we all know this means consider the common diagnoses more often than the rarer ones. In the beginning, you want to teach the basics of emergency medicine. You want to teach the ACS, the kidney stones, the PEs, for example. Of course, as they progress in their career, it's important to teach the rare diagnoses and the can't miss diagnoses, but we want to ensure that the resident has a strong emergency medicine base that we start early on in their training. I'm going to cover is called the 2-minute observation. Traditionally, what this refers to is the faculty member observing the student interact with the patient. So you stand at the bedside or in the doorway while the resident is obtaining the history and performing the physical exam. This allows you the opportunity to ensure that the resident is asking open-ended questions and then transitioning to more closed-ended focused questions, that they're doing a complete and accurate physical exam. If you notice anything that they're doing incorrectly or something that they can improve upon, you can either jump in at the time and show them, or you can wait until they're presenting that patient to you and discuss it with them then. It's also beneficial for the resident if you flip this and have the resident watch you interact with the patient. As the instructor, you may ask questions that allow you to obtain further information from the patient in the process of developing your diagnoses. And they can also observe you doing a physical exam. Perhaps there's a maneuver that you perform that they hadn't thought of or hadn't done, or perhaps there's a maneuver you're doing that they're doing incorrectly. So there's a lot that can be learned both from you observing the resident and from the resident observing you. Okay, that concludes the lecture. I hope that you find one or more of these bedside teaching methods helpful and can start implementing them into your practice. Thank you.